Good evening, everybody. Welcome to our Care Fertility Introduction to IVF. It's lovely to have so many of you here with us tonight. I suspect there's probably people who have maybe had some thoughts about having treatment, people who are completely new to the world of fertility and the whole process. So hopefully we can give you some helpful insights moving forward tonight as to what we do here at Care and what we can offer you as patients moving forward. So we'll just move on to the next slide. So typically nobody wants to come and see us and have IVF because we hope that people will get pregnant naturally and not need to. But for lots, it might be the only way and the only option for them to move forward in their desire to have a family. And we are most importantly there to support you through that difficult journey. And I think I feel very privileged to look after our patients and to guide them through that process. And as a team at Care, the most important thing is that we want you to feel supported, we want you to feel informed, and we appreciate that when you first come to see us, that it's an awful lot of information to take in, which is why it's quite helpful to attend an event like this, so that you have a little bit of information to start with to give you an idea about what we can offer you. But like I say, the most important thing for us as a team is to make sure that you feel supported and empowered to make the right decisions about how you progress in that fertility journey. So there's lots of causes of infertility, and for lots of our couples, there might not be a particular reason as to why people aren't getting pregnant. And we suggest, dependent on your medical history and your age and lots of other factors, some couples we might suggest will take 1 to 2 years of actively trying before they come to see us to discuss treatment. For some people who have a history, let's say polycystic ovarian syndrome or endometriosis, or are concerned about advancing age, it may be that you want to come and see us sooner. And certainly I think now, yes, we do see people who have been trying actively for a couple of years and haven't got pregnant, but I think we're also increasingly seeing people who are thinking about their future fertility. They might be considering the fact that they're not in a relationship, and they might want to consider fertility preservation and possibly freezing of their eggs, for example. Or they might want to come and see us for some initial investigations for a fertility MOT, just to find out whether or not there's anything they need to be concerned about in the future. And I think hopefully through education and kind of empowering our patients, we're helping them moving forward with giving them the information that they might need to plan for the future. So lots of different things that we think of as causes for infertility and things that we can diagnose. So moving on to getting the right diagnosis. The initial steps, once you've made your inquiries, will be to consider having some pre-treatment tests. And generally that involves some blood tests, and that might be looking at things like a female patient's AMH, which is the blood test that looks at your egg reserve. It might be pelvic ultrasound scan to check that the pelvic organs appear normal and there's no concerns raised, and also semen analysis. And the important thing with the semen analysis is some men can be a little apprehensive about coming to do that. There's the possibility of doing a sample at home and bringing it into the clinic within the hour, or producing a sample on site, which is probably more common because it takes the pressure out of people trying to get there with that sample in time. But baseline investigations before we have the initial consultation are very helpful to give us a little bit of guidance as to what the problem might be, and to also give you that information at that appointment so that we can hopefully plan treatment, inform you better as to how we would best guide you through things, and give you that opportunity to move forward. So consultation takes place normally once you've had those initial investigations done. We tend to send out clinical questionnaires for both for if you're a single person, just for you, if you're in a couple, for you and your partner. And that talks through your medical history and anything that you think might be relevant to us. So if you're a patient that's had treatment before in another clinic, or you've had some initial investigations through your GP or in one of the NHS hospitals, by all means, we give you the opportunity to upload those. So we've got that information beforehand. So we're happy to look at any investigations or any details of previous treatment that you've had. So that can help to guide us moving forward as to how best to manage you. So we talk through in that appointment the results of the investigations we've done or your fertility journey to that point. And then we talk through in detail with you what potential treatment options might look like, and also how the process would work, and talking about things like the timescales, dependent on when you want to do things. At that initial consultation, we will also briefly talk about the different cycle options for you with regards to the financial side of things, but that generally is taken over subsequently after the appointment by our dedicated patient services team, who will give you all the detailed information and the tailored treatment options and cost estimates that are specific to you as patients. And that will also include things like your medication, and specific dosages will be taken into account when we're raising those estimates. So next, we're going to talk through the IVF process and what it involves. And I appreciate that we do this every day of the week. And for us, it's obviously a very familiar process. But for lots of people, when we do that initial consultation, it's quite common for people to feel a little bit overwhelmed at this point, because it's an awful lot of information to take in. So it's great that you've joined today just to kind of touch on some of the aspects of the IVF process, to give you a little bit of an overview as to what it involves. So essentially, IVF is a way of essentially allowing fertilization to happen outside your own body. So it's collecting eggs and using sperm to fertilize those eggs to create embryos that are essentially early pregnancies. So the initial process, what we tend to do when people come to see me in clinic and they're ready, they decide that they want to go ahead with treatment. Initially, prior to the process beginning, there'll be lots of steps that we go through with you, and most importantly, we very much support you through those initial stages. So there'll be some paperwork to fill in the form of consent forms. There'll be some initial investigations that need doing before eggs and sperm going to the laboratory, such as viral screening. You'll have things like your nurse planning appointment. We'll give you a very detailed protocol, which is, as I always say, it's a little bit like a recipe with a step-by-step guide to exactly what you need medication-wise, and when, and what dosage, and what time you're taking it, and when you're coming for scans. So you've got on paper a list of all the things that the treatment will actually involve. So with regards to the process, some clinics you'll call with day one of your cycle. It's in some clinics you'll start a tablet medication in the lead up to starting the injectable stimulation medications. In some clinics you might go straight into that. So the ovarian stimulation is essentially a daily injection that you administer yourself at home. Most of the medication will be delivered to your home address generally, for ease, and you will have a nurse planning appointment where they can talk you through the process of giving the injections. Often people find this step quite daunting because they worry that they're not going to do it right, or they're going to find the use of the needles quite difficult. But we're there to guide you through it, talk you through it. There's often videos on the portal to give you a little bit of an aid memoir as to what you're actually doing. And obviously, from the point of view of, you can ring the clinic or the out of hours on-call service if you need to, if you've got any questions about this. So this isn't a process that we want you to find daunting. We'll support you through it. And like I say, it's generally daily injections for around 10 to 12 days that you will have to stimulate the ovaries, which will hopefully then produce follicles on the ovaries, which will hopefully contain eggs that we will collect at the egg collection process. So dependent on your actual history and the clinic that you're going to, you will have a scan or scans to monitor your response to the stimulation that you've had. And that involves an internal transvaginal scan where we will look at the response to the stimulation by measuring the follicles on the ovaries. And they appear as kind of fluid-filled structures that we will measure to try to get an estimate, sorry, as to whether or not you are ready at that point for egg collection. In some cases, patients might need a day or two more on that stimulation to get them to that perfect stage before egg collection. But on the whole, it's generally between 10 and 12 days of that stimulation before you're ready for egg collection. So when the clinic do that final scan and they tell you that you're ready for your egg collection, generally that evening you will have your final HCG trigger injection to mature the eggs, and then a couple of days after that final scan, you'll normally come into the clinic for the egg collection procedure. And essentially what that involves is you come into the clinic, you'll have some sedation for the actual procedure. So you'll feel drowsy, but actually you'll be aware of what's going on, but comfortable during the procedure. And it's an internal scan with a very fine needle on the tip of the probe, which will go into those follicles that you've developed as a result of the stimulation. And that fluid will be drained into tubes and will go into the lab where they will look under a high-powered microscope to identify the eggs that have been collected during that collection process. So on the day of egg collection, you'll be told how many eggs have been retrieved. And on that same day, if you're in a heterosexual couple, for example, your partner will produce the sperm sample, and again can be done at home and brought in within the hour or on site. And then again, the sperm is analysed on the day and a decision made as to whether or not we're going to go ahead with conventional IVF, which essentially means taking the eggs and a prepared sample of the sperm and allowing nature essentially to do that fertilization process for us. So in IVF, we always say that the best and fastest sperm gets into that egg and self-selects itself. If there was a concern about male factor infertility, or we're worried about the quality of the sperm on the day, then we can look at doing a process called ICSI, where we inject the sperm into the egg to aid that fertilization process. So I think it's important, obviously, to know that from a male perspective, the quality of the sperm can vary from ejaculate to ejaculate. And so we sometimes see people where the sperm on the day might not be quite as good as the sample that was produced when they were having their diagnostic tests done. So I think it's important that anyone coming through for treatment is aware of the different options that might be presented to them on the day of treatment. So as I've said, the sperm can be prepared and injected into the egg to overcome any male factor fertility issues, or if the quality of the sperm on the day is not as good. There's also technology that we have here at Care called Zymot, which is a membrane filter, which helps to select the sperm used for ICSI, and is a great adjunct to ICSI treatment because it reduces oxidative stress and DNA damage within the sperm, which hopefully will then lead to better quality embryo development. So on the day of egg collection, we'll tell you how many eggs we've retrieved, and then on the day after, you'll get a call from the embryology team to let you know how many of those eggs have fertilized. And at that stage, the embryos will begin their growth and development in the laboratory setting. So we aim to do blastocyst transfer, which is generally a day 4 or 5 transfer, dependent on the timings and the clinic that you're at. We also will offer you different options from an incubation point of view. So there's the option of standard incubation, where the embryos go into the incubator and they're left to grow and develop over that 5-day period. And then on day 5, they're taken from the incubator, looked at under the high-powered microscope by the embryologist, and graded according to their development. We're also very fortunate here at Care to have the wonderful Care Maps technology, which essentially is continuous video surveillance of your embryos in the incubator. So they're still left undisturbed, as embryos like to be left, but they have a constant video surveillance looking at their growth and development over that time frame of the 5 to 6 days that they're in the incubator. And it allows us to establish whether or not those embryos have developed in a textbook fashion and met their milestones on each day of their progress, or whether or not they may have got there in the end, but were a little slow on at different stages of their development. So it then gives us a Care Map score out of 10, such that we can correlate that with with the female age to see what the chance of success with that embryo will be moving forward. It also allows us the opportunity to select the best quality embryo for you if we're doing a fresh embryo transfer, because there may be a number of embryos that look the same on that final day 5. under a microscope, but it might be that there's one that's met the milestones beautifully along the way that is the front runner as far as embryos are concerned. So it gives us a lot of additional information. The other thing that I always say to patients as well with Care Maps technology, we also have information if you have Care Maps for patients who maybe don't do quite so well from the point of view of embryo development. So it gives us the additional information if the embryos don't make it to blastocyst or a poorer quality, we can get additional information as to where those embryos have fallen down in that process to try to further help you moving forward with potential changes to treatment and looking at ways to overcome problems that we come across. So lots of information gathered from the Care Maps technology. So with regards to the freezing of embryos, some patients will have a fresh embryo transfer, and then if they are fortunate enough to have additional embryos that we create as part of that treatment cycle, then they'll be offered the option to freeze those embryos. Frozen embryos, from a care perspective, we are selective about the embryos that we choose for freezing, because what we want is for you to have a really successful chance of that frozen embryo thawing successfully for future treatment. So our thawing rate is a 98.5% survival for embryos that have been frozen. Patients can opt to have something called PGTA, which is biopsying of their embryos. And all of those patients that have PGTA, for the majority of them, they will have their embryos frozen at the point that they have been biopsied, and then we will arrange a follow-up appointment to discuss the results of those biopsies with you. So with regards to embryo transfer, the process essentially is a little bit like having a smear test. For those patients who've had a smear, they will understand it's a speculum examination, and we put a very fine soft catheter through the cervix, the neck of the womb, into the uterine cavity, which you can see on the screen now, and sometimes that will be done in most cases through ultrasound guidance, so we can see the tip of the catheter, we can see the embryo being deposited. And then once that's done, you can get it up and about and do normal activities as you would normally. Difficult part of this treatment is that wait after embryo transfer. We always say treat yourself like you are pregnant, continue your supplements. You'll often be given progesterone pessaries that you will continue to use from the egg collection right through to the pregnancy test and beyond. But it's difficult, that 2-week wait, because obviously at that stage you've invested so much time and effort and emotion into what you've been through. So the top tips I generally tend to give people are, always have things in the diary to look forward to, things to distract you, and just look after yourself, and so that you feel that you've done everything you can along with us to make this treatment successful. So with regards to the pregnancy test, you'll do a pregnancy test at home. You'll let us know what the outcome is. And then if the pregnancy test is positive, which we obviously hope it will be, then we will arrange for you to come in for a scan to confirm that everything's okay from a pregnancy perspective. And that's generally around the 7-week mark. If the test is unfortunately negative, then we will arrange a follow-up appointment for you to discuss the next steps moving forward and what that looks like. So what can we do to improve your chances of success here at Care? So I touched on PGTA of embryos. So PGTA is a technology where we essentially take, as you can see on the screen here, some cells that are analysed to check the genetic makeup of that embryo. And I'd say that it's a technology that we're using increasingly for patients to reduce their time to pregnancy, to focus and streamline the treatment, such that when we replace your embryo, we're replacing a genetically normal embryo that's been screened to try to reduce chance of implantation failure and miscarriage, and to give you the best potential to have a healthy ongoing pregnancy. With regards to the different options for patients, there's lots of different motivation for having PGTA. Sometimes people, as they get older, where maternal age is increasing, and we know that there's an increased chance of genetic abnormalities, we might opt to screen embryos routinely at that stage. It might be that if you're wanting to go through an embryo banking package, for example, where we plan treatment for now and thinking about the future, we biopsy any embryos that we freeze so that you know what you have to work with moving forward. So, say, for example, you come to the clinic and we talk about the bigger picture of what you want to achieve as a family moving forward. If you want more than one child, we might start to talk about utilising this time effectively by creating embryos and banking embryos. And as part of that process, we will biopsy those embryos so that we only store genetically normal embryos for use both now and in the future to make the most of the time that we're doing that initial treatment. We've talked about the Care Maps AI and the additional information it provides for us when we're selecting embryos for transfer, and also looking at the quality of the embryos you're creating, as well as also, like I say, detecting where things haven't gone as well as we'd hoped and how we can then look at improving or adjusting treatment moving forward. So other considerations. For some of our patients, we might not need to do treatment in the form of IVF. With regards to our IUI, the types of patients I tend to recommend it for are single women using donor sperm, same-sex female couples wanting to use intrauterine insemination. Sometimes it might be patients who are unable to have sexual intercourse who will have IUI. And essentially what we're doing, it's a very similar process to the one that I've described for embryo transfer. We do a speculum examination, and using that same soft fine catheter, we replace the sperm into the uterus, and that can be done as part of a medicated or a natural cycle in line with ovulation. We see lots of same-sex couples at Care and have different options for them. So we give you lots of support when it comes to potentially using a donor, and that might be donor sperm, it can be donor eggs, or potentially donor embryos. We are very lucky to have our dedicated donation team who are there to support you every step of the way in that donation process. We also have shared motherhood, which is also known as reciprocal IVF. So for same-sex female couples, we have a shared arrangement whereby one of you will donate the eggs and go through the egg collection process to create the embryos, often with donor sperm, and one of you will then have the lining of the womb prepared, ready to receive the embryo and to potentially be the person that carries the baby, essentially. So lots of our patients have had a really positive experience from shared motherhood because it allows you both to participate in the treatment and be actively involved in the whole process, which I have to say the feedback we've had is that patients really enjoy this process from the point of view of both feeling involved in it. Some of our clinics also offer surrogacy, and again, we have dedicated surrogacy support team to guide you through the process that can obviously often be a little bit daunting at the start. But like I say, the dedicated surrogacy team and the people that offer that treatment in the clinics will guide you through that process of how we can support you through the surrogacy journey. So why choose Care Fertility? Most importantly, the thing that I'm so proud about at Care is that we have a team that will support you and are actively involved in your fertility journey every step of the way. And I work at the Care Cheshire Clinic and the Care Liverpool Clinic, and I'm incredibly proud of the teams that I work with and the support that they're able to offer patients. And our feedback is fantastic from the point of view that people feel that lots of the different teams that they come in contact with during their treatment provide that support and a positive experience. So the patient inquiry team is often there to answer common questions, to provide with the information, the consent forms, the cost estimates. You've got obviously the nursing and medical staff to talk you through the treatment and provide that treatment for you. There's lots of resources like the Care Resource Hub. There's counselling service available to all our patients at any stage in that journey. And I always say that that can be for individuals or for couples together to have that support counselling at any stage that they need it. and obviously the social media side of things, and the Salve app, which is an incredibly useful way of us passing information on to you and for you to get in touch with us. So we're lucky to have a number of clinics, 16 clinics in total across the UK. And the thing that I like most about that is that we have lots of clinicians, nursing staff with lots of different areas of expertise. So we're very fortunate not just to be a single standalone clinic. We have the experience of a huge number of clinicians who we can draw upon at any time. We have a huge network, so the medical directors, for example, like myself, across the group will liaise and discuss difficult cases, learn from each other. We offer lots of different technologies across the clinic, so we're really fortunate that we can offer you kind of that bigger picture in the world of fertility as to like different experiences that we've had and different treatments that we can offer you. Again, we have very competitive success rates across all age groups, and we're very proud of constantly reviewing our success rates and wanting to offer you the best treatment and the best chance of success. So with regards to the payment side of things, the admin and patient services team will be able to guide you through the different options available for you. Some of those options have interest-free credit, so that we can help you with the finance side of things. There's also refund programs such that if you have a, let's say, 2-cycle package and you're not pregnant, that you get a partial refund on your treatment. We also offer multi-cycle programs, which I find that the patients that I see do like, because they know from the outset that they've paid for the treatment that they're potentially going to need. So that might be a 2-cycle program, for example, with frozen embryo transfers included as part of that package. So it gives you that reassurance at the start of the process that you have a better understanding of what the cost of the treatment will be. And some of these packages also include the care maps, video surveillance as part of that package. There's also packages for donor eggs, for example, which when you come to us to discuss the possibility of having donor eggs, both the clinicians and the dedicated donation team will talk you through that. So getting started, I mean, the most important thing is for us to gauge at the very start how we can help you here at Care to navigate the world of fertility, and often in that is very much dependent on how long you've been trying and what you want to achieve and whether or not it's now or in the future. So we offer a fantastic pre-treatment bundle which includes your initial investigations, so pelvic ultrasound, semen analysis, AMH test, routine blood tests that are important to have done. So full blood count, looking at things like whether or not you might be anemic, vitamin D levels, and it's important to have folic acid and vitamin D supplements whilst you're trying to conceive. We look at your thyroid function, we look at HbA1c, which is a marker for diabetes, and also that bundle includes your 45-minute consultation with your dedicated care fertility doctor, who will talk through the results and tailor any specific treatment recommendations to you as an individual or a couple. So we work hard to try to make sure that we support you through this fertility journey. We do truly appreciate that, like, as I've said at the beginning, we do this every day of the week, but we appreciate for a lot of couples and individuals, it's a bit of a minefield, and it's difficult to navigate your way through it and to understand when you need to come to us, what tests you need to have done, and when it's the time for you to consider treatment. And what I would say is that I think the important take home is that we're trying to empower individuals and couples to make the right decisions at the right time in their life. So, like I say, it isn't just a case of having fertility treatment when you've been trying for a long time and it seems like the only option. We can also preempt things by looking at your fertility assessments, by considering things like egg freezing and offering you advice at an early stage, even if you don't feel ready to take the plunge and have treatment right now. So I believe that my colleagues have been looking at the chat, and they are looking to see if there's any questions from people that are watching this tonight. So we can have a little look and go through some of those now. Um, but certainly, I would encourage anybody who's considering embarking on treatment or wants to just explore options to get in touch with our inquiries team and to talk through what we offer, you know, make inquiries about what might be suitable for you either now or in the future. So I think we're just going to see if there's any questions that have been put to us. Right, so I've got some questions here in the chat. Um, does low sperm morphology at 3% increase the risk of embryo abnormality? So I think the thing I always say about sperm morphology is the more important factors overall, I feel we think are the motility and the concentration of the sperm. When we assess the morphology, we're looking at a very small proportion of the sample when we're assessing the morphology. So it isn't on its own, it's not a concern generally about potential embryo abnormality. I think there's lots of other factors that feed into the risk of embryo abnormality that is something, you know, for example, maternal age, but I think if it's something you're concerned about, we can certainly discuss something like that at a consultation based on the overall picture to give you a better understanding. Um, what's the chance of success for low sperm count? I think this is with 0% morphology. So again, you know, when it comes to the sperm side of things, there's lots we can do to improve your chance of success from a sperm perspective. So what I tend to do is take a detailed history from any male patients where there are concerns about the sperm quality. We talk about your lifestyle, so things like smoking, alcohol, drug use, medications you might be taking. We talk about things that might increase scrotal temperature. So the common ones are things like saunas, steam rooms, hot tubs, heated seats in the winter, which we all love, things like cycling. All of these factors can play a part, as can things like viral illness. So over the years of doing this job, we've certainly seen effects of COVID on sperm. And the important thing is that sperms produce continuously, as opposed to as women, you know, we're born with all the eggs we're ever going to have. Men continuously produce sperm. So the important thing is that the parameters can be improved over time, and we can suggest supplements that can help to improve the sperm quality as well. So when it comes to the sperm count, there's lots and lots of things we can do to hopefully improve that sperm quality. Also, there's the option to potentially freeze sperm ahead of treatment if we're concerned about the quality of the sperm, so that we have backup frozen sperm moving forward. So again, I think if you've had sperm parameters that haven't been normal, come and see us, have a consultation. We can talk through potential options to help improve that quality of the sperm, as well as thinking about how best to proceed with treatment moving forward. And when it comes to chance of success, as I've said, it's often multifactorial and lots of things to take into consideration. And that's across, you know, if it's a heterosexual couple, for example, talking about maternal age and egg quality and egg reserve, as well as the sperm parameters as well. Um, so I've got another question here about, would somebody not ovulating need IVF, or would they be managed differently? So for some women, particularly those who may have polycystic ovaries, um, it might be that ovulation doesn't occur predictably and on a regular basis. And people don't have to have polycystic ovaries to have anovulatory infertility. There are simple solutions, assuming that the fallopian tubes that we can check are open and clear and that the sperm quality is normal. We can potentially offer tablet medication with tablets such as clomiphene or letrozole, which are used in the early part of the cycle after as the period started, to induce ovulation that way. And we can offer you monitored ovulation induction cycles here at Care, where we do a scan and we check that the ovaries again have responded to the medication, and we tell you obviously when to have timed intercourse to increase the chance of success. So people who are who aren't ovulating don't necessarily need to go down the route of IVF. It might be that ultimately that's what we resort to doing, but for some patients, ovulation induction medication alone will achieve the pregnancy. Um, so when we talk about age for success rates, is that the woman's age or both? Is one of the other questions. So I would say that female age is unfortunately probably one of the more important factors. There is evidence of male factor, the side of things deteriorating with age also, but female age and ovarian reserve is probably one of the more important factors. But yes, age does play a part for both, but predominantly more so, dare I say, for the woman. What are my thoughts about mild IVF and conventional IVF for women over 40s, as there seems to be contradictory medical views on this? Um, it's a difficult one from the point of view that I guess it depends on the response that people have to stimulation. So some slightly older women, so women in their 40s, let's say, dependent on their ovarian reserve, have varying degrees of response to the medication that we give them. Um, and one of the factors that we find more challenging is that they may be more likely, as we get to the point of advancing maternal age, to create genetically abnormal embryos. And that's when PGTA, which we've talked about tonight, comes into play. Consideration of donor eggs, dependent on how cycles with our own eggs have gone. So for some patients who are over 40s, as they mentioned in the chat here, higher doses of stimulation might get us to the point where we have a reasonable yield of eggs at egg collection and a reasonable yield of embryos that can then potentially be tested for genetic abnormalities before they're replaced. For some women, regardless of whether or not we give them a high dose of stimulation or a lower dose of stimulation, we may essentially still get the same outcome where we maybe have one or two follicles that will hopefully contain eggs. So it isn't that we routinely would do mild IVF, which is kind of generally kind of lower dosage of IVF. We would tend to give you initially the best opportunity by giving you those higher doses of stimulation to maximize that ovarian response. But it might be with time, as we get to know you as a couple, and we look at response to the stimulation, that we potentially reduce the level of stimulation if we're getting the same outcome regardless of the dose that we're using. Hopefully that answers that question. As a 32-year-old, I've been told my AMH is on the lower side. Is there a cutoff point where IVF isn't possible? So this is a really good question because, you know, sometimes it isn't just about age. We do see women who are younger who might have issues with their ovarian reserve. And certainly I look after a number of patients with poor ovarian reserve at a young age. I look after patients who have premature ovarian insufficiency, which is essentially premature menopause. And there isn't a cut-off per se where we wouldn't allow you an opportunity to go ahead with treatment. I would say that when we get to an AMH of less than 0.2, we obviously have to tell you that the chances of success will be very low. But from an age perspective, we also take that into account when thinking about low ovarian reserve because we know that women who are younger are potentially more likely to create genetically normal embryos. So what I would do is if you're worried about AMH levels and age, come and see us to have a consultation and we can actually look at that bigger picture of you as an individual or you as a couple to establish what the best next steps would be. And for some people, it might be that they explore their AMH with a view to potentially egg freezing. And the AMH gives you a lot of insightful information as to whether or not that egg freezing process, which we can offer, will be benefit to you. So in that scenario, I would suggest come and speak to us, come and have a chat and we can talk through potential options and likelihood of success. Does PCOS affect the number of eggs that can be collected? So that's again a very good question. And polycystic ovaries means that we're more likely as individuals to develop something called ovarian hyperstimulation. So this is when women have an over response to the medication that we give them. And we warn all couples who come through for treatment when they have their stimulation about the possibility of over responding or under responding to the medication. So when people don't respond as anticipated, we might get to the point where we give you additional stimulation in a hope that we can continue to grow those follicles. Worst case scenario, we may abandon a cycle before you get to the point of egg collection. The flip side of that is that some patients, particularly those with polycystic ovaries, are more prone to developing a condition called ovarian hyperstimulation. And essentially what that means is that the patient experiences bloating, tenderness of their tummy, they can be breathless and then quite sickly, and the ovaries essentially enlarge and develop lots and lots of follicles, and there may be some fluid in the pelvis as well, which can irritate the pelvis. So in those scenarios, we will give you a slightly different trigger injection to dampen down that over response to the medication. And we're likely to consider at that point creating the embryos in the lab, but potentially freezing those embryos such that they can be used when you've completely recovered from that hyperstimulation. So the egg numbers for patients with polycystic ovaries do tend to be greater at the egg collection. It doesn't always necessarily translate into a much larger number of embryos, but essentially in any given cycle, we're looking for hopefully at least one good quality embryo that will give you a chance of pregnancy. But yes, with polycystic ovaries, we are cautious about the dosage of the medication to hopefully do what we can to prevent ovarian hyperstimulation. And we will also do a slightly earlier scan in patients with polycystic ovaries to check their response and to make sure they're not over responding to the medication that we're giving them. How much experience is there working with women with adenomyosis? So, for those who aren't sure, adenomyosis is essentially endometriosis within the muscle layer of the womb itself. And it's a continuum essentially with endometriosis. So some women will also have a degree of endometriosis with adenomyosis. So we have lots of experience dealing with patients with both endometriosis and adenomyosis. And again, I would urge you, if you are potentially worried about a diagnosis of endometriosis or adenomyosis, or you're thinking about your fertility options, knowing that you have these diagnoses, that again, you come and speak to us and talk to us, and we can talk you through the impact that those pathologies in you as an individual might have on your treatment and guide you about anything that potentially needs to be done ahead of treatment, or also talking about kind of the fertility preservation side of things for people who might be about to, say, undergo treatment for endometriosis. So again, come and speak to us. We can individualize the care that we give you based on these diagnoses. Can you undergo IVF if you have an endometrioma? Yes, you can. We will normally do your pelvic ultrasound scan and have a look at the endometrioma, which, for those of you who aren't aware, is essentially endometriosis within the ovary. So that can become a problem when you're having IVF treatment, because the endometrioma, dependent on the size of it, might impact the ability of the ovary to develop follicles, which will contain the eggs. If we damage an endometrioma during an egg retrieval, it can also increase the risk of pelvic infection. For some patients, they might have a very small endometrioma, and generally 5 centimeters or so would be the cutoff for not potentially intervening. But once they get above that level, or if people are particularly symptomatic, then we may consider potentially intervening before going ahead with treatment. But lots of women will go ahead with having IVF treatment with an endometrioma. They can grow in response to the stimulation, and obviously they can grow in pregnancy. So again, the best thing to do is to make an appointment to come and see us so we can talk through your particular findings on scan, and your symptoms, and discuss kind of the diagnosis as a whole so that we can guide you as to how best to move forward with that. So we'll look at the next one. I've been told I have a thin endometrium. Is that likely to affect success? This very much depends on whether or not the thin endometrium is just an incidental finding on a pelvic scan, or whether or not it's something that happens in treatment. So generally, the lining of the womb, the endometrium, varies in thickness throughout the menstrual cycle. So it starts off very thin after you've had your bleed. It then builds up into what we call a trilaminar endometrium, and then it kind of thickens in the luteal phase, so the latter part before the period essentially starts again if you're not pregnant. So it's looking at the relevance of the thickness of the endometrium at that particular point in the cycle. If somebody's referring to a thin endometrium in cycle during treatment, that can affect implantation. It can affect the ability of that embryo to successfully implant in the uterus and create the early pregnancy. And there's lots of ways that we can overcome these issues with medication and different options for you moving forward. So it is something we have a lot of experience in, and we can offer lots of different treatment options if it's something that happens during the course of your treatment with us. Um, would IVF help someone that has trouble maintaining lining in luteal phase, even with medicated cycles and cyclogest? So this is possibly somebody who we know with ovulation induction. So going back to the conversation we had about tablet medication to help you to ovulate. There is a tablet clomiphene, which can have a negative effect on the lining sometimes. Letrozole is also used, which has been mentioned here. IVF, in my experience, if we're struggling to achieve a pregnancy with ovulation induction tablets, it can be that patients just don't respond as well as we'd hope to those tablet medications. It can have a negative effect on the lining. With the stimulation medications, my experience is that the lining tends during those doses of stimulation to respond better than it does with some other conventional treatments such as letrozole and clomiphene. So we can certainly look at ways of overcoming those problems. If we were to do a fresh cycle of treatment and we had frozen embryos, again, there's lots of tricks up our sleeve when it comes to different ways to develop that lining up to a suitable thickness and quality, most importantly, to support an ongoing pregnancy. So yes, I would say the answer to the question would be that actually IVF and subsequent frozen embryo transfer with different medications to support the lining can certainly help you to achieve a pregnancy. And then there's a question about adenomyosis and issues with implantation and how can it be avoided or accounted for. Again, there's lots of research going on into looking at the impact of adenomyosis and endometriosis in successful fertility treatment and implantation. It's difficult, I guess, because what we need to do is optimize that endometrium and look at all the other factors to try to, where possible, increase chances of success and to overcome problems. We're obviously mindful of the adenomyosis, but it's not something that's necessarily reversible. We take it into account when we're thinking about how best to manage you. But it is difficult to overcome. However, we see lots of different patients who have adenomyosis that's noted on scan and they do achieve pregnancy. So but don't be too disheartened or worried if there's been a suggestion of adenomyosis on scan. Please, can I describe the PGTA process further? Does it pose any risks to the embryo? So I think, so the PGTA process, again, this is quite a complex process where we are obtaining some cells from the embryo, which are then grown as a cell line in the laboratory, and then the genetics of that embryo are analysed. With regards to the risks to the embryo, interestingly, I chat about this topic with my embryology colleagues all the time because we talk about patients being concerned about the process. The majority of the time, my colleagues in the lab tell me that the process is absolutely fine from the point of view of the embryos surviving that biopsy, freezing and thawing process. There's a process called lysis, which can happen to the embryos, where the embryos can gradually kind of disintegrate and deteriorate during the process. But my overall feeling from talking to my colleagues in the embryology lab is that ultimately, if the embryo is of poorer quality or it's on the verge of being suitable for biopsy or not, the question is whether or not that embryo would have actually created a healthy ongoing pregnancy or not anyway. So I certainly would say that the statistics overall from the point of view of PGT-A, very good. It's something I do recommend to my patients. We always, in any process in fertility and anything in medicine, will weigh up the risks and benefits, the pros and cons of that particular option for people. And I certainly will recommend PGT-A to an awful lot of my patients that I see. And I genuinely think that the benefits do outweigh the risks. But again, if it's something you're considering, we can arrange to see you in the clinic to talk about it in detail, in particular, taking into account your own fertility journey, talking about embryo quality, talking about age. And also, if you feel that you want to have a chat with our embryologists, we can arrange that for you, and arrange for them to have a conversation with you about in a little bit more detail about the processes that go on in the lab and potential risks and just the statistics that we have for our current practice. So the next one, I have PCOS and blocked fallopian tubes. I'm 30 in April, and I've been told I have good ovarian reserve. How likely am I to be successful in the first round of IVF? Well, that's a tricky one, because I guess the difficulty for me, as a patient, as a doctor, is that when people come to see us, it's often very difficult. If I had a crystal ball and I could say, was the first cycle going to be successful? Then, we'd be very lucky. But we don't always, we can't always guarantee, obviously, that that first cycle of treatment is going to be successful. Ultimately, when we're doing IVF, we're overcoming the issue of blocked fallopian tubes. So that's one factor to take into consideration. With blocked fallopian tubes, sometimes there might be something called a hydrosalpinx, where there's fluid on the tube, and that fluid on the tube can leak into the cavity of the womb, and it can create a hostile environment for the embryo that's replaced. So in some cases, with regards to the blocked tubes, we will suggest that you have the fallopian tubes either removed or clipped ahead of treatment. So that's something that can have an impact on success rates. It might be that you've had a blocked tube, but there's never been any suggestion of fluid on the tubes, and we can just carry on as normal. But it's something to bear in mind. With polycystic ovaries, again, it's often that you need to go through the IVF process to get pregnant if you're not ovulating and releasing eggs, and we've not had successful ovulation induction, or if there's an issue with the tubes and we don't feel that ovulation induction is going to be an option, then IVF would be an option. I guess we need to take into account all these different factors. So the reason for infertility, the age, the quality of the sperm. Having a good ovarian reserve is reassuring, but there's lots of factors that play into this. So again, coming to see us to talk through all of the different factors for you would give us a good indication as to what we could give you as a quoted figure, for a rough idea on the success side of things. That said, obviously, we give you figures based on our experience and on your individual case. However, it is sometimes that until you have that first cycle of treatment and we see how you respond, and obviously other factors come into play, like I say, like age and biopsy results and things like that, we will then be able to give you a better idea moving forward about chances of success. But that first cycle of treatment can be very telling as to how successful someone's going to be moving forward. Hopefully that answers that question. So that concludes our evening tonight. That's the last of the questions. I'd like to thank everyone for joining us. Hopefully we may see you in one of our clinics very soon. But most importantly, I wish you all the best on your fertility journey. And please do get in touch with us here at Care, if there's anything we can do to help you moving forward. I believe that our team are on hand if you need to get in touch with them to discuss anything. But most importantly, best of luck.